Late toxicities of chemotherapy are a major issue, and we obviously want to maximize the cure rate, but minimize late toxicity. In some situations, that's not possible. In other words, in some cancers, we need to use drugs that we know may introduce a late toxicity to maximize the cure rate. Nobody would elect not to be cured because of a 3 or 4% risk of leukemia, for instance, in Hodgkin's disease treatments 8 or 10 years after their treatment. In breast cancer, one of the thrusts of research in the last 10 years has been, how can we modify treatments such that we minimize late toxicity? Adriamycin is, or was, a very commonly used drug in breast cancer, and in the last 5 or 10 years it's become apparent that, at least in many instances that we commonly used Adriamycin, we don't need to use that drug anymore. That's especially true in the case of tumors that overexpress this growth regulatory gene called the HER2/neu gene, which is overexpressed in about 20 to 25% of breast cancers. Herceptin is a drug that has greatly improved those patients' prognosis, but it has some mild late heart effects. And when it was combined with Adriamycin, the cardiotoxicity became a much more important issue. When the trials were reported in 2005 of what are called non-Adriamycin HER2-based chemotherapies, that incidence of cardiac problems, namely congestive heart failure, went way down. So we now have eliminated a lot of potential heart problems in patients with more aggressive breast cancers. In addition, in patients with better prognostic breast cancers that still need chemotherapy, we have replaced an Adriamycin and Cytoxan regimen with a regimen of drugs called Taxotere and Cytoxan, when that combination has no late-term heart problems, whereas the Adriamycin had a 4 to 5% incidence of cardiomyopathy or congestive heart failure. So one of the goals has been to minimize heart problems. One of the other major issues we deal with, obviously in much younger women, is the whole fertility issue. And there are a number of trials looking at different combinations of drugs or additive drugs that might be able to preserve fertility in a situation in which we still need to give chemotherapy. The other side effect that often comes up is what's called chemo brain, or this sense that women's brains sort of don't work like they used to sometime after chemotherapy. It's been a very interesting area of research, and the results have been somewhat murky. With the general kinds of chemotherapy that we give for breast cancer, there's not a lot of hard scientific data that would indicate that we have done something bad to the brain. I have a lot of patients that complain about minor issues, some forgetfulness, things like that. But I must say, I've not had people that, for instance, used to be a CPA and feel like their IQ has dropped 20 points and have to do something else. So it's a nuisance issue, I think, for breast cancer. For patients with bone marrow transplant, however, the leukemia lymphoma group, there actually is some data that very high dose chemotherapy may do something to the brain that we can describe as chemo brain. But in the breast cancer population, at least at this point, it doesn't seem to be a huge clinical issue.
Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
and I want every woman to know
about personalized breast cancer treatment
and the genomic test.
a test that helps guide a woman and her doctor to the best treatment options for her.
Pass it on.